So the topic given to me is on immunosuppression, but I was highly impressed by Dr. Biswa's statement about the steroids being the mother, because sir said it doesn't, nobody else takes care as much as a mother do. And I would say steroids, like a mother, have an unconditional support. So whenever you have a problem, you go back to steroids. So it's like mother. Whenever you have she's always there to support you. So wonderfully said, sir. So with this, I move on to the double-edged sword, um, as far as the immunosuppressive therapy is concerned, and what to do and what not to do when we start our patients on immunosuppressive therapy. So first thing is we have to be very clear about the indications of immunosuppressive therapy in uveitis. And since all of us who are practicing uveitis are by and large clear about it, at times we tend to be overconfident, and this is where we make a mistake. So we have to be very clear, and the indications are whether we are giving immunosuppressive therapy for for the steroid responders, patients who are not tolerating steroids in any form. Um, if there is a poor response to systemic steroids in the form of persistent uveitis, the uveitis is not responding well, or there is recurrence of inflammation, or there is paradoxical worsening of uveitis. Third, when the patients in whom systemic steroids are contraindicated, for example, CSR or uncontrolled diabetes or hypertension. Intolerance to systemic steroids, patient is an old patient, there is risk of osteoporosis, fractures, adverse events with previous steroid therapy if there is a history like this, and when there is a contraindication to intravitreal dexamethasone implants where you have uveitis with hypotony, you have CSR, steroid responders in form of high IOP or significant cataract, aphakia or scleral fixated IOLs. Now the second point that we need to consider is pre-existing challenges in uveitis. Of course, when these patients who are enrolled for immunosuppressive therapy, now these eyes have already run an aggressive or a chronic course of uveitis, and we know that they have a limited visual potential despite starting them on immunosuppressive therapy. So initiation of systemic anti-inflammatory therapy or an antibiotic therapy in uveitis requires only minimal basic workup like blood sugar, blood pressure. But when we have to start immunosuppressive therapy, it needs a much more elaborate workup. You need to have complete counts. You need to have the biochemistry, the LFT, and the RFTs. The duration, another challenge is the duration for which the immunosuppressive therapy is prescribed is going to be much longer. It's going to be at least 2 to 3 years. It's going to have a lot of financial implications, and patient compliance has to be kept in mind. We have to discuss this with the patient. It's not like steroids where your job is done maybe in a period of 3 to 4 months. It's going to be long term. Adverse effects of immunosuppressive therapy have to be strictly monitored under the supervision of an internist and should not be, I would really say, should not be prescribed by an ophthalmologist alone. We may think of a time in future where we are very confident in prescribing ourselves, but I would not recommend. I work in a center which is a multidisciplinary, so I have that advantage. So despite having that advantage, I have never started any patient on immunosuppressive therapy myself without involving the rheumatologist because I cannot take that risk. So I would recommend the same for those who are in private practice. Don't take it lightly, and I'll show you an example which will be a life learning lesson for all of us. So though rare, these complications can be fatal. So rarity is not the thing that we can enjoy, but fatality is the thing that we need to be really worried about. So coming to my point, the focus of discussion, double-edged sword. So what to do when starting immunosuppressive therapy, and then later on what not to do. So what to do is, you've heard from the previous speakers, rule out an infectious etiology of uveitis. Even if you have a slightest doubt that this could be an infection behind the uveitis, hold on to your immunosuppressive therapy. Patient counseling is a must about why we are starting immunosuppressive therapy, what are the potential adverse effects, what's going to be the cost, especially when you are starting drugs like mycophenolate, and what's going to be duration of the therapy. Because when you're starting, you're telling the patient that I'm I have given up with the conventional treatment like steroids and antibiotics. Now I need to put you on this therapy, and why? It's going to be long. Patient's consent is a must, and you have to ensure patient compliance, because there are cases, for example, of VKH where you're starting with IVMP, you're putting them on a tapering dose of steroids, you're starting them on immunosuppression. The patient is doing quite okay at 6 months, but if the compliance is bad regarding immunosuppressive therapy, patient comes back with a very bad recurrence, and then you have to tell the patient that if you leave this drug in between, we are going to go back to basics, and we're going to go back to the cycle of IVMP. So the moment patient hears that, he or she is convinced that I cannot take that risk, because these IVMP and high dose oral steroids, 1 milligram per kg body weight per day, is very difficult to tolerate. So it's better to tell the patient, we'll go back to that, so don't miss these immunosuppressive drugs. Rule out any pre-existing immunosuppressed state, not only by the history, but by the labs as well. Baseline blood tests are mandatory, has to be supervised by an internist or a rheumatologist. Rule out pregnancy and lactation. That holds for every drug that you're starting in ophthalmology. For example, I'll just deviate for a minute. We see a lot of patients of toxoplasmosis, and many of them are young girls and women, and we really don't bother to ask if they are married, they are expecting. And I have seen these errors where we don't ask the history. We start the patient on anti-toxo treatment, and the patient has had to go for abortion, because when the gynecologist comes to know the patient is on anti-toxo, they advised MTP. So please be careful, rule out pregnancy and lactation. So coming back to immunosuppressive therapy, frequent and regular monitoring with LFTs, CBCs, and RFTs. Now, what not to do? List is small, but very important. Do not give in infectious uveitis. We've covered that. Do not ignore if there is any adverse event reported by the patient, either symptomatically or indicated by the laboratory tests. Even if it is a subtle complaint, please listen to it. Do not prescribe the full dose initially. Unlike steroids, where we start with a full dose, like 1 milligram per kg per day, but immunosuppressants, we start with the lower dose, step it up, and then go to full dose in a few weeks. So we don't start full dose initially. It has to be stepped up very periodically under monitoring. I'll quickly take you through this example. This was a young girl, a 13-year-old, presented with bilateral panuveitis. Choroidal granulomas were confirmed on ICG. You can see she had Cushingoid facies because of prior oral corticosteroid therapy. She was given elsewhere before she came to us. So since she was a 13-year-old girl, we sought our pediatric rheumatology consultation for the cause also and for these Cushingoid effects, because we had to start the patient on steroids. So following the laboratory tests, a diagnosis of presumptive ocular sarcoidosis was made. Oral steroids were started. And because she needed steroid-sparing therapy, methotrexate and azathioprine was started after a normal baseline hemogram. So this is what you're seeing. Her baseline tests were. 2 weeks, her panuveitis resolves, but because we had ordered, our protocol is we get the baseline CBC, RFT, LFT done. We repeat them at 2 weeks. We repeat them again at 2 weeks. And because we are starting initially at 50 milligrams of azathioprine, that is recommended by our rheumatologist. 2 weeks, we monitor the tests. We hike it up to 100 milligrams of azathioprine. Again, we see LFTs, RFTs, and CBC. If normal, we hike it to 150 milligrams per day. And that's the usual full dose that we give, 150 milligrams OD for a normal body weight adult. Now, 2 weeks after starting azathioprine in this child, she complained of complete loss of hair, alopecia totalis, with hyperpigmentation of knuckles. You can see here. And this time the report that she had brought, because we advise it anyways, her hemoglobin, TLC, platelets, you can see, suggestive of pancytopenia. So we immediately referred her to a pediatric rheumatologist. Azathioprine was stopped. Injection GCSF 300 microgram was given subcutaneously for 2 weeks. That's the treatment for it, for neutropenia. Mycophenolate mofetil was added. An NUDT15 mutation study revealed homozygous variant. There was normalization of hemogram at 1 month follow. That means another 1 month from the baseline. So these are the serial photographs at 2 weeks, 1 month, 3 months, and then 8 months. And you can see there is complete reversal of alopecia. There was complete reversal of knuckle hyperpigmentation. So azathioprine is a well-tolerated drug. Its side effects are rare, but it can cause the dreaded complication of myelosuppression in genetically predisposed individuals who exhibit mutations in TPMT and NUDT15. It's an early marker of azathioprine-induced myelosuppression. So whenever you see alopecia in any of these patients, please be cautious, hold on, get the test done, take a rheumatologist's opinion. Alopecia usually precedes myelosuppression, so it comes before myelosuppression, but it can also occur simultaneously with myelosuppression. And knuckle pad hyperpigmentation is even rarer, and it's strongly associated with megaloblastic anemia. Both these enzymes influence metabolism of azathioprine. So their any polymorphism then results in accumulation of active 6-mercaptopurine, which gets converted to 6-thioguanine nucleotide metabolites, producing cytotoxic effects. So as a result, in the disruption and the mitotic activity of the actively growing hair, the anagen, more catagen follicles are seen than anagen, leading to hair loss. So while massive hair loss is well recognized, say following azathioprine as a toxicity sign, there is no report of knuckle pad hyperpigmentation as a direct adverse reaction of azathioprine, and this is basically because of megaloblastic anemia, and that has been reported to azathioprine. So we linked this knuckle pad hyperpigmentation to megaloblastic anemia secondary to azathioprine. So I'll not talk about the mechanisms in detail. So GCSF was given because it reverses neutropenia by regulating the neutrophil production in the bone marrow. So this was the treatment in this child. So that's led to the reversal of alopecia and knuckle pad hyperpigmentation.
I would request you to conclude, Dr. Reema.
So
out of time.
As per our setting in India, both these tests, the mutations are low, and it's an expensive test. So we don't recommend these testing in all the patients who are started on azathioprine or any other immunosuppression. So they have to be done as on a case-by-case basis. So to conclude, this kind of fatal toxicity is enough to make us learn even by one example. So I would say that we have to be very careful in starting any form of immunosuppressive drug in our patients, and we have to be alert in recognizing these signs, clinical signs, before the laboratory tests tell us the diagnosis. So it's a double-edged sword. The benefits of immunosuppressive therapy in sight-threatening uveitis justify their use in uveitis, but their adverse effects, though uncommon, can be serious and may prove fatal. Thank you very much.
Thank you so much.